Brilliant.
Hello everyone, thank you for joining us for this specialty careers webinar in core surgical training and CP building. My name is Adina, I'm the specialty careers webinar lead for Minded Leap. I would like to give a good thanks to all my team on the specialty careers team in Minded Leap. And I'm happy to introduce our speaker, Dr. Prakrit Kumar, who obtained this very competitive academic fellowship position in trauma and orthopaedics in a run-through program in the West Midlands. I'm going to hand over to Prakrit now. Thank you.
Brilliant. Thank you very much, Dina. So basically what I'm going to go through is core surgical training, how to build your portfolio up, and then just day in life of a core trainee. So going through it. So specifically, so there are different routes into surgical training. I think most people think that the standard route of CT, ST is the only route, but I thought I'd highlight different routes to it. So I have actually taken a different route as well. So we have our standard med school, and then we have our F1, F2, and after that, usually most people apply for core surgical training, which is 2 years, and then do specialty training in their specialty, so trauma orthopedics or whatever the surgical specialty from ST3 to ST7, and then you CCT. There's also alternative pathways, so you can have neurosurgery straight run, or you have academic routes. So an academic route is usually it's called the academic clinical fellowship, and it comes with a national training number, which means you have to compete again, and it's a straight run through post, and it allows you to focus on academia 25% of the time. Sorry, 25% and 70% roughly. So that's the route I went for because I'm interested in research, and it allowed me straight run through number. Just so I can highlight it. Alternatively, there's other pathways, just called CSER, which is basically a non-trained pathway for it. So you basically do the same number of years and have this kind of format where you do 2 years core training and 2 years specialty training, but it's not formalized, and you have to kind of create your own. Make sure you log all your numbers and everything. Make sure you get the adequate sign-offs. And generally, from what I've heard, it's difficult. But still, I'd highlight that there is another way to get into surgical training or become trained in surgery if by this pathway. But generally, I recommend one of these two. Building towards this career is so I would say all your achievements start as early as possible, because you can start as soon as you get into med school. And it really helped because that's basically what I did. I started actually quite late in med school, around 3rd or 4th year. Managed to get most of my points for core surgical training within those 2-3 years, meaning our F1, F2 could just be done for MRCS or learning surgical skills. So the first thing, make sure you get this document. It's easy online, just type it, CST self-assessment scoring 2024. One important thing to know is it changes every year, so don't expect it'll be the same every year. So for example, take the 2024 one and then look up 2021 and look how much it's changed and how much harder it's got. So I would get this document as a reference, but always aim for at least like 20 to 30% above what they're asking now, because generally that's what the trend is. They always try to aim a bit more than this. So section 1, so it's split into different sections. So first is section 1, which is like commitment to specialty, and it's quite neatly split up. Previously it used to just be boxes, 20 points, but now it's separated into relative subsections, and it used to have the MRCS. The reason why I've kept it is because it might get back in at any point. We're not actually quite sure as trainees ourselves. But one personal recommendation I'd say is if you're just in creative surgery and you want to like pursue it, the earlier you get it done, one, it allows you to not worry about exams for at least FRCS, and two, I think people take you a lot more seriously in theatres if you've completed MRCS compared, like for example, if you haven't. So I always recommend doing earlier. I only did it in part 1 in F1 and then part 2 in CT1, and I wish I did it a bit earlier, like F2. So I strongly recommend that. And then I'm going to go through each of these sections now. Oh yeah, so going to MRCS, it's sat in September, January, and April. Those are the rough sittings. I would say you need roughly 4 months or more. I mean, I took 6 months to prepare, but 4 months is what everyone else generally goes by. And in terms of RCS, a common question most people ask is, should you say RCS England or RCS Edinburgh? Ultimately, it doesn't matter at all. I just went for England because I'm from Birmingham, so it's close by to me. London, as opposed to going to Edinburgh for each time, but it doesn't effectively matter. And so the resources, this is what I, in terms of how I revise for this, so part A and part B are very, very different. Part A is all like basic science, anatomy, etc. What I would do this is like use EMRCS online question banks and ask your seniors for like and questions that they've had. What's the best way to say it? So like they would give you tips what question banks are most relevant, especially people who are most sat it. So I remember my year, my RCS was very, very good, but some people might suggest later years past test is good. So I would get advice from the most recent seniors and go from there. I'd aim to complete MRCS roughly 3 times before the exam, and you should be okay with that. In terms of book, everyone varies. I just use draft book, but you don't use any book that. Some people didn't use books, people just did MCQs back. MCQs are focused, but I used the books because my anatomy wasn't as good going in at F1. So this is what usually needs to be 4 points to be passed Part A. Obviously, the section's removed now. So I would strongly recommend you doing it, even though it's not on the section. As one, they might bring it back, and like I said earlier, it helps you with data, etc. Okay. So another section that's been removed, unfortunately, is surgical courses. And this is quite simple, actually. I'd also recommend it, one, just for your portfolio, and just it's useful for you to go to. The standard courses, I think it's on the next slide. Yeah, this is the ones I went to. I'd strongly recommend the basic surgical skills, simple, easy, funded at the Royal College, or you can get it funded by your deanery if you have one F2. ATLS, you could only do F2 and onwards. So what I did was I signed up for the wait list early on, like when I was in F1. So by the time the slot came up in F2, I was ready to do it. So I'd recommend that. It's very, very hard to get. So anywhere in the country that you get a spot, I would definitely attend. And it looks very good, especially if you're applying for themed or CSD. Then these are the other ones I just did just to show a bit of breadth. So I did urology, which is a really simple, easy one and it's accredited. So it's just you can literally type up online NCP, and it's online, free. You can do it in your own time, pre-recorded, asynchronous, and you've just got 1 point easily just from one day's work. And then teacher is very similar. There's different teachers online. So we do one at University Hospital Commentary Warwickshire, 2-day in-person one. But then this, I remember in my F1, F2, I did it online, and similar teacher, and there are the other online ones as well. So I'd look at your deanery, see if they offer it, and if they don't, then start looking online because it'll be covered then. Yeah. And other courses, I've listed all the ones that are accredited, but it's not comprehensive. Yeah, there's loads more that are accredited. So, but it should be a simple one, an easy one that you should cover, even if it's not in section. Like if the section's removed, one, they might bring it back, and two, it's just generally good that you cover all these before core training. It really helps. Good. This one is, I don't think this will really go. It's always going to be there. The numbers are actually getting higher and higher. So 40 or more cases, very key is it has to be assisted or it cannot be observed. Start early. So you can start at med school. I used to go once a week, which was very easy because I mean, by the end of the year, I got all my numbers. Simple. But even if you were starting F1 or F2 latest, it's still very doable. I would what I do is like probably go to day surgery list or trauma list, because they're usually quite quick. So if you spend one day, you'll get around 5 cases. So if you spend 4 weekends, you've done your you've met your numbers. What I'd recommend is every year this number keeps going higher and higher. So I would recommend increasing it, just aiming for like 50, 60, as they might change it. Yeah. So in terms of satisfyingness, it doesn't have just to be in your specialty. In fact, you know, I got most of my numbers from like general surgery, vascular, because for example, like things like abscesses, which are only like 5-minute max operation, you can do back to back, and like to get easily 5 to 7 in a day, which means that it just means get more numbers. And things like vascular allow you to like these all, you'll get transferable skills. So I also don't really focus on the specialty, but more on assisting, getting hands-on. In terms, some people do say this, so it's just not observed. The key thing, you can do anything from assisted to supervised, trained, scrubbed, unscrubbed to performed. I don't think most of anyone will be able to perform ones yet, just assisting, but just mentioned it as well. And the key thing out of everything from this whole talk is, unless you've logged it somewhere on Mark, like got a certificate for it, it's basically like I haven't done it. So you need to make sure you log every case. So the key things I always get up, so I do it then and there. So as soon as I finish a case, I log the computer and then log the case so I don't forget. People do it after all 5 cases. It's really up to you, but you need to have the hospital number, day, operation, and quite a few key details. So I would do it then and there personally. In terms of signing this off, ready for CSD applications. So the way you should do it is get this consolidation log. It's on the e-log. Then when you get the consolidation log, it'll come up with all the different things you've done, like AV fistula, whatever you've assisted in. And then at the end of your F1, or just before you're going to apply to CSD, so usually an F2, log out and then ask your consultant to sign it with, let's see if it's on the next slide. Yeah. Ask your consultant to sign it with his name, GMC number, and the fact that he's a consultant. Because you need all 3 to ensure that it's valid. Key things I would say that, like tips to improve this bit, is to start early with theatres. To start with just going and assisting, scrubbing up, then work your way up. Start like asking to like start suturing skin, and you can work your way down, and then start to get more involved. And the best place I would say to this is probably DGH, because I got my best operating time in a DGH in F2. And in big centres, often they're quite consultant-led, so you don't get as much exposure. So if you're a med student, I would say try and maybe apply for a DGH if you're looking for operating time. But it shouldn't be a major factor, but just something to be aware of. Brilliant. Okay, so next bit is surgical conferences. Again, this should be fairly simple. You should be able to attend. I've split it into 4 because most people think it's only your specialty. So the first ones I would go to are the big 3. So I'd go to your specialty, whatever it is, which is whether it's orthopedics, trauma, plastics, general surgery, etc. Go to your relevant one. So for us, orthopedics is BOA or BTS or trauma care. There's also ACIT, which is generally for all surgeons, associated surgeons and training, which I strongly recommend as well. They have measuring categories, so it's a good place to present as well. Then you have student-specific conferences. These are conferences organized by like University of Birmingham Trauma Orthopedic Society, etc. These it's still grey whether this is accepted or not. So I would strongly recommend still to go for at least. So when it says 3 surgical conferences, I'd aim for at least 5 and go for the professional accredited ones. Then what else is useful to me? The allied specialties. So I don't. So if you have an abstract or anything that's orthopedic related, you don't just have to put in orthopedic. You can put it in similar sounding specialties like plastics. If you're doing hands work, you can present it in BAPRAS, so or allied specialties. So just don't try and broaden your horizon as well in conferences. And the one common thing that most people forget is there's like medical education conferences. So say you run a teaching program and it's a bit novel, the way you do it is very different, things like that. There's always medical education conferences that you can go to as well and submit your work. So it's something I didn't use that much in med school and started using now. Thought I'd mention it to all of you guys. And then again, the strict criteria, make sure you log it, get a certificate. It has to be a specific way. So if you look on the appendix of this, it'll tell you exactly how to do it. Brilliant. Okay. In terms of surgical experience, slightly different. This is actually quite simple to organize. I would organize a taster week. It's quite simple. You just arrange it with your hospital you're affiliated with. If you're in F1, F2, you can elsewhere. So I actually in fact did it in where I am now because I was very interested in robotic orthopedics. So I came and I can get time for the wards. It's kind of a nice week to do something in your specialty, something you enjoy, and yeah, time for the wards. So I would recommend that. And also, if you're a med student, I would also recommend doing elective in your specialty. And this is an easy way to get several different points. So in the elective, organize a med student. Organize elective, apply for funding, and if you get a grant, that's a prize. Then go to the elective, assist, get your surgical numbers up, and then after elective, write it up, publish it, and submit it for prize, and you get a prize. So you get 2 prizes, a publication and operating time, just with 1 4-week elective. So that's what I would personally recommend. Yes, and then I think this is most people have this. It's very unusual to have in F1 F2 not having a surgical placement, but just make sure you have one. And this is quite key, actually. Make sure you have it in F1 or the start of F2 before the application, because if it's not before, then I'm not sure if it fully counts. So I had one in F1 and one in F2, so it can be, but just make sure that's the case for you guys. Brilliant. So,
sorry to interrupt, Dr. Kumar. We've seen in the chat that the audio is interrupting.
okay.
Would you mind maybe turning the camera off and see if that improves the audio quality? Yeah. Thank you. Can you let us know in the chat if it's still interrupting? Sure,
yeah. So this section is on the, what's it called? So this is a summary of all the of what we've just gone through. It's just section 1. I just wanted to put side by side of how it's changed just from one year to another. So it's become from, like, for example, they removed their MRCS, they removed the surgical courses, they've pushed up operative numbers from 30 to well above 40 now. So my guess is they're going to put it to 50 next year. It's just a guess. They've kept 3 surgical conferences the same, but they might increase it to 4 or 5. And they've swapped it around. If you see, previously elective was the most important, but now it takes a week. So just make sure you get all 3, because you never know which one they're going to clear as the most important. Yeah. Next slide. Brilliant. This is a simple-ish thing to get, but it's actually, most people really struggle with this. So what I'd recommend is, so it's a QIP, and you have to get it. You have to get 2 cycles, as you can see here, and it has to be surgically themed. So I wouldn't do it something like it has to be surgically themed. People get caught up with that, and make sure it's 2 cycles and it's closed loop. So easy, really, really simple. I would pick something easy and simple rather than something really complicated that you're looking to publish. So I would keep this and the publication separate. So I would do the quip as a quick like tick box exercise with 2 cycles, and then I would do the other do your other projects for publication. People get stuck with trying to do all in one sometimes with this section only, and don't fully achieve either, if you know what I mean. So I split them simply. So what I did was very, very basic. It was very simple. It took me less than a month or 2 months max in my first or second rotation. So I found out there was no theatre booking form. That's a problem. Then I implemented it. Form. I showed that less time was wasted for booking patients. Then I said, what would you improve? So that's 1 cycle complete. I asked, what would you improve next? They gave a few suggestions, added to the form, asked, is this much better? Yeah, they said yes, improved. So that's 2 cycles done. And it's quick, easy, simple, took maximum 2 months. And I would, yeah, the main thing is obviously, like I always say, log. So make sure you get a certificate with this exact wording. So just say like, Prakrit Kumar was involved as a lead in all aspects, and just use the exact same wording, and say he participated in all stages, implementing, etc., project surgical theme. And this way, you know you'll definitely get it in the what's it called? Like you'll definitely need the points will be in the like query. And then the next section is like part of this, which actually catches a lot of people out, is you have to present this project nationally for full points. You present it regionally, so obviously present it at your local trauma meeting or audit department, but then also present it nationally. Present this nationally or internationally. And the way to do this, I would say, is probably don't go for the conferences like BOA, etc. Unlike, you can try, but it's unlikely to get accepted. So I'd go for small things. And also Metal have been really, really helpful with this. So they've all presented projects for me. Like I presented projects with Metal nationally, and it's one of these QIPs. So they offer access to a lot of different like opportunities to present your surgical audits. So I would present it there as my recommendation. In terms of meetings or conferences, it's the same as the last one, I would say. So when we went earlier, I would stick to your professional ones, so BOA, BTS, trauma, ACIS for one, or medals, one I would recommend for QIPs because most likely to get accepted. Obviously, there is grey area whether it's RCS accredited or RCS supported, which ones would count. But I always stay in the safe side because when no one's quite sure of which one it is. So I would stay with the accredited, the official ones, because no one will I've explained this 2 cycles. Clinical has to be very clinical, and surgical especially. I've given you some basic examples. So I did the theatre booking form, but can do, everyone does VTE. It's quite simple ones. There is a research and med ed section, so you can do this as a surgical one. However, I don't know if they will change the points. So I didn't use this. In fact, I stuck to my clinical surgical one with these forms. But this is an easy way to get it. If you can't find this, it's very, very easy. So easy med ed one that everyone kind of does this. So look at your department, show there's no teaching on, I don't know, fluids or whatever that's easy. Give a talk, do a survey to show that. Give a talk on fluids. Get the feedback forms, show you've improved their confidence, and then deliver the session for the next set of trainees 4 months later. Show it's even better, 2 cycles, and then get a consultant sign off. So that is simple, but I would stick to clinical just to be on the safe side. This section is it's not that bad actually, because it previously used to be 2 sections, and the one thing I'd like to say is that it might at any point again. So it see 2 separate sections: one for prize, one for prizes, one for presentations, and one for publications. But now they're just together. So make sure I would still get each individual one because you don't know if they're going to change it. I'm just going to go to my next slide just so. So publications, I'll go through that first. So it has to be a PubMed indexed, as we all know. So it can't be like there's loads of journals out there which accept papers, but they're not PubMed indexed. So it needs to have a PubMed ID at the time of your publication application. So if you don't have PubMed ID, it doesn't count. So it has to have it, yeah. So there's two different routes that I use mainly. So there's obviously the clinical one. So whatever projects that you do, I would publish them with their respective. So I did my master's, I did all British cancer, I did it in my specialties. So like the knee journal, British joint journal, etc. And then you can always publish it in allied specialties. So for example, I published one of my trauma papers in anesthesia, actually, in anesthetic journal. So because it was rejected in a trauma journal. So don't forget about using allied specialties. And then there's obviously supervisor journals. Excuse my slides. Supervisor journals. And they'll be able to guide you better about how that journal likes it written. So my supervisors were, again, just of injury and trauma. So I've used that. And then a common one everyone recommends is BMJ. I haven't used it actually, but I know lots of colleagues who, once they have their project idea and data collection extra, they go to BMJ and say, look, this is our idea. This is what we'd like to publish. Are you interested? And they help you with each different stage. I haven't had personal experience with this, but I know that they do that. Then a common thing that most people, or most med students, or everyone have to forget about is you can publish in medical education journals. So for example, if you've delivered a national in-person teaching program, you can publish it in these journals saying how you organized it, and then what the novel features are for it, why you're publishing it. So like usually it's to say that, oh, this is a model that we used, so other people can create the same kind of teaching programs in their specialties. And it's an easy way to get publications without without basically asking a supervisor, etc. And I strongly make sure you don't forget about that avenue. But again, it has to be PubMed indexed. I've listed a few papers like PMG. It's the main one I used, but there's others like Journal of Surgical Education, MedEd, and Clinical Teacher. I'll just mention one more thing about publications. Yeah, make sure, so it previously used to be 2 papers, but now they made it 1. So make sure, always go above, so make sure you get 2. Another easy one would be systematic review. Simple and easy to do. You don't need data collection. And if you know how to do one, there are great courses outside, like there's Anchor's one. There's loads of different courses. There's your university usually offers some. And yeah, I'd strongly recommend it. I used Anchor Kajuras, but any of them are really, really good. Then, okay, so next section is prices. So it's removed now, like I said earlier, but I wouldn't, I would still strongly recommend to get some, just because it comes up maybe later in higher surgical training, and or it might be brought back up, brought back into application next year. So just make sure, I would say, get 1 or 2 at least. Simple ones to get, actually I didn't get any of these, but most people get is like in your degree, so they get distinction or honors or etc. So yeah, I would do try and do that, but I wouldn't worry too much about it, because I wasn't top of my year or anything like that. So yeah, I wouldn't worry about getting a degree if you can. I'm just telling you that it's an avenue. It's not the only avenue there. Conferences, there's usually the okay one, especially as a med student. So if you submit to med student conferences, so not med students, sorry, just normal conferences with like ACIT, etc. They usually have med student sections, and which means that you'll only be competing on the med students, and usually most people get a prize that way, which is a very easy way, and it classifies as an all prize presentation here at the top of this section 3. So I would strongly recommend that if you're a med student. Then there's also there's loads of other avenues most people forget about. So it's like So there's essay competitions. Just look online for them. So yeah, I think you have to do a lot of searching and digging. So I look at MRCS, look at BOA, MRC. There's loads of different ones, and you just have to look at different organisations, see what they have open. Often the smaller ones don't have as many people applying for it because it's not less well known. For example, like the BOA one, everyone knows this one every year, but it's smaller ones are less likely to be applied for, which probably means you have a higher chance. But yeah, I still would recommend doing it. It's only 1,500 words, and it's quite an easy way to get a decent prize. And if you do well and write it up well, you could even submit that as a review. So 2 birds with 1 stone kind of thing. Then you have other competitions, which I haven't done that much at all, to be honest, but there's loads of different types, like surgical skills ones that ACIT do, like how fast you tie, how fast you suture, etc. Those are good ones, but I actually don't have much experience in that. Sorry. And then there's medical education ones, which are really good. So like, how has your society, say Trauma Orthopaedics Society at University of Birmingham or whatever perspective, how have they helped and how have you led them? Why do you feel like there's loads of things like health service journal awards, and you can just use your society if you're the president or anything, and say how and submit it to these awards and show how you've shown an impact. It's a quite good way, especially as med students or foundation doctors, to show and get a good prize. And then you have your grants, like I mentioned earlier. So if you're doing elective, or even if you're doing a small project or anything, I would always strongly recommend applying for a grant. Yeah. And then if you get it funded, you get money for going on elective, and it's a prize. It's a win-win. And then also go look out for uni prizes. It's very, very good. Sometimes they have essay competitions there, small research types. So I won the Own Way Distinction one, which is the best researcher in the year. But just keep your eyes peeled on your local university page as well. So it's not, you don't only need to get from a degree, which actually I didn't get any of them. There's loads of different ways. So try your bet in all of them, to be honest, and then you'll probably get lucky in one of them. Brilliant. So section 4 is on teaching programs. It's quite a difficult one, and it's getting harder and harder, to be honest. So previously you were able to just organize Zoom one, and you submit, send a link all around the UK, and it would get you full points. But now it's getting a lot more harder, especially they made it such a you have to do a face-to-face teaching program, and you have to do it at a regional level. And if you think about it, especially as a med student, it's quite hard to organize to different universities in the same like hall or room. And so there are it does take a lot of effort, but I would strongly recommend it as well. One, in-person teaching programs, like organizing everything, you'll get a good networking opportunities, especially from the consultants, whoever delivering the talks, and that will lead to projects, etc. And then 2, you can collaborate with different universities. So you could do like a national, like you could do like a London one, etc. And yeah, so what I would say is it has to be, they've only said it 4 or more. So in previous years it's been 3 months, another time it's been a minimum of 6 sessions. So generally what I would go for is a 3-month format, so 6 sessions every fortnight, and generally that has met all of the criteria. And if you do it in person between 2 universities, you met your criteria. And then one key thing that was there before, move now, but I would still do it, is make sure you deliver one of the sessions, so that there's evidence that you've taught as well in that program. So that's a really the easy one. For example, I can give an example. It's like orthopedics. I did one of the 6 joints: hip, knee, ankle, shoulder, elbow, spine, and yeah, it's very. If you just 6 sessions, 6 joints every fortnight at my local university, hired out local rooms, which is free, and then got different what's it called, different other universities to come along to regional, and make sure key again, like I said, needs to be a log. So you need to get a consultant letter that says this exact wording, and you need to evidence the feedback. So make sure after every session you have feedback forms. And it says here you've shown the ability to identify a gap. So a way I've done that is I usually just do a survey beforehand at my local university saying, ortho teaching is not great, etc. I wish I had more teaching on this, and that way you've had that filled out. But make sure you include all of this in the letter by the consultant, because that's the key. Like I said, face-to-face, I would say minimum 6 sessions, so there's 3 months, regional, so at least 2 universities, 2 hospitals, etc. And it has to be surgical, and a teach one. There's another section which used to be contribute regularly to teaching more than 4 a year. So I would generally say if you're a med student, I would try and teach. We have near peer teaching courses, so try and teach in other courses as well, and let vice versa, let people, and then you can let you guys all tick the boxes, as well as if you're at F1, F2, I would just do bedside teaching, very simple, but obviously that doesn't qualify for the regional section. But just make sure you're regularly teaching, so do 4 sessions, whether it's near peer teaching or ward based, and also organized teaching program. Brilliant. So now they have this section, which is really annoying. So this is the only place where I actually lost. So it's training in teaching. So you have to have a training in teaching. So what I'd say is do a train the teacher course. Look at your local deanery. They should be running one. If not, West Midlands do one, I know, and it's usually covered by your study budget, or there are ones online. Make sure it's accredited. And it has to be 2 days at least. Don't get caught with that. And then yes, that's it. One thing I'd probably recommend is, a lot of people did this, is they did a PG cert in their first year of F1. I mean, I didn't do that, but it's a good way to get on with it, and it actually always comes up. So in your high specialty applications, whether you apply for ortho, whatever, surgical specialist, vascular, etc., this section comes up again. So the earlier you get your PG cert or whatever in F1, it's really good. So the best way, if I had to do my F2, I'd probably start at the end of final year, you finish around April time, revise for your MRCS 4 months straight, and you should be ready in September. Sit in September, hopefully pass, and then sit your part 2 in later that year in January. So it's done in F1, and sign up for your PG set F1 as well. That means everything is done pretty much in your F1 year, and you're ready to apply. You can just focus on the application in F2, and in core training, you're just learning surgical skills. So that's the ideal best way to do it, but I think it is quite hard to do all of that in 1 year. So I'll leave it with you guys how you do it, but strongly recommend getting MRCS out there. Yeah, so some people did an F2. The reason I wrote F2 is because if you're academic, it gets funded, whereas if you do an F1, generally they don't fund it, although you can ask university and see if you can do it. In terms of courses, I've just stated a few that do it. Medics Academy, I know do it. It's online easily. I would definitely ask your deanery. Brilliant. Yeah, so this is just an example of how you can literally achieve most of the CS in your med school early on. So, like, operative experience easily, you can do 40 cases. It's one a week. That's even if you go in once a week, you'll get 3-4 cases. So you should be completely fine with that. Then surgical conferences, you should be able to go 3 or 4. I always keep as a rule to go to the big ones every year. So that's maybe which are orthopedic and which trauma, so that's 2, and then just generally go to 1 more. So keep 3 conferences. I always do that every year, and I'd recommend. It's a good time going with your friends, a good time, and also getting some points at the same time, and it's funded. So strongly recommend that. And then surgical experience, make sure you organize taster week in your F1 year or just before your application in F2. Key thing for all of these points actually is it has to be done by October, November if you have to. So don't think you have all of your F2. You basically only have 1 or 2 months for F2. But just focus on getting everything done in F1, to be honest. Yeah. So surgical experience, get your taster week done in F1 or to get your elective in med school, and also the one make sure you have a placement in F1 or start of F2. Yeah, in terms of publications, I got this is my first publication actually in med school, and it was part of my elective, like I said. And yeah, it gets 4 points. I'd always recommend getting 2. Like I said, always 1 above what they ask because they're likely to improve. And then I've already explained this, but yeah, just go for a simple quip, in my opinion. And then if you present it, Medal's a really good place. They're very friendly and yeah, they accept. So I strongly recommend that. And then teaching experience. So I did loads of teaching programs, but make sure it's in person for 4 points, not online. But if you want, like, I strongly recommend just doing it in person personally, because you're going to need this point here and later on. So yeah, and then training teaching, I didn't get my 4 points because I didn't do a PG cert. Yeah, I did train teacher, so I got 3 out of 5. So this left me with 50 out of 52 at the F1. So it's very, very doable if you just start early. And even if you start an F1, again, most should be achievable except the publication part of it. But I have had people like get 2 or 3 within 1 year, so it's doable. So something I thought I'd just mention briefly is academic clinical fellowship. It's a whole nother talk itself. It's a completely different. It's not completely. So you have to meet all the basic standards of CST. So I would still do all of this exactly, but plus you have to do for academics. I would say you have to get minimum publications, presentations, and prizes. And then they use this and you write white space questions. So it's basically 5 questions that they ask you. You have to, it's like a personal statement effectively. And then based on these 4 things, they give you an interview, and based on the interview, you get your spot. ACF, I strongly recommend it because it gives you dedicated research time, 25% off for research, guaranteed run-through number. I strongly recommend that as an academic myself, but again, I'm biased. But it's a whole nother talk in itself. But I just want to let you know, either way, you don't have to do CST, whether you give ACF or normal CST. So make sure you just get CST on point. Like, just make sure you finish this in F1. So again, change is always constant. I just want to keep reiterating, just because the 2024 one says what I've said, doesn't mean 2025 they're going to up the cases to 60. So generally they'll keep upping it. So always go about 20-25% above what they ask. So I remember when I looked at it first in med school, it's 15 cases. Now it's gone on 40. So I'd always go 20 above what they ask, so 60 at exit. Again, audit, make sure you do 2 cycles minimum. Face-to-face teaching, don't compromise online. If you want 4 points, if you're willing to accept a bit lower, it's online, that's fine. But I would strongly recommend this because you could use the same points for SA3, so do the same. And then one thing I wish I did early on is PG cert F1 or an F2. But I think I would do an F1 personally. Like I said, the ideal format is what I said earlier: September MRCS, Part A, January Part B, out the way. And a common thing that really, really useful actually for MRCS is make sure you do it quickly. So if you Part A, plan to sit Part B within again 4-6 months, because they ask the same knowledge. I left it along the edge due to personal circumstances. Long time, 1 year. So I would strongly recommend just doing back to back, because it's easier, you don't have to provide the same knowledge. So just a quick out a day in a life core training. Everything's going to be this amazing surgeon that you can operate all the time. I think a lot of the time I'm just opening, closing, putting the final screws in, etc. So don't expect all like glamour or everything. You're learning all your basic surgical skills. I think you properly operate when you're a registrar. Again, just my experience I'm talking from, but you're doing your basic surgical skills. So what might be good is if you learn all your skills F1, F2, so simple things like transfixing, etc. You can do a lot more in core training. So I just thought don't go really high expectations. You will just be doing assisting, etc. But it depends on specialty. For example, when I was doing my general surgery rotation, I got to do most of the appendix, if not like, and like orthopedics, skin, almost DHS. So there's loads of like basic operations they do let you do. But on the majority, like ankle Weber fixation, it's unlikely to do most of it. So the key of core training is to get all your basic surgical skills: closing, opening, and how, for example, orthopedics, how to use so in terms of clinics, it's actually quite very varied. I would say the focus is more on the on-calls and nights. The idea is to get your on-calls and nights. Ideally in CT2, you want to be at reg level. Why you should do is, as a CT2, I'd be with the reg. I would answer the bleep, and he would just sit by me to make sure I'm doing the right things. So step up early, and then in clinics, so usually a bit more senior. So I recommend it's also required for your portfolio. So usually you should go once a week, about once a week. But again, I don't think many people actually do. But you should. And then there's obviously the ward on-call shift. Just a lot of people think as soon as you become coordinator, wards, which would be so nice, but yeah, you don't get that privilege. So we still have to do what's just like F2s. So there's the on-call shift where you basically after hours, you know, bleep regarding ward stuff as well. But yeah, all in all, it's a good thing, but don't just go with really high expectations. Set achievable targets such as learning basic surgical skills, attend a few clinics, and make sure you're ready to be a reg. On calls wise is probably the most important as a core trainee, ready for reg. Yeah, brilliant. I think that's it. Perfect. Yeah. Do you guys have any questions? I think how do you want to do it?
Thank you very much for this amazing talk. We have some questions in the chat. I'm going to run through them. Guys, feel free to add your questions as we go along. I'm going to try to go through as many as possible.
Yeah, sure.
So the first question is if you're happy for us to share the slides at the end of the presentation.
Yeah, sure. That's fine. Yeah. I'll send it to Dina.
It's going to be uploaded, and the presentation is recorded, and it's going to be available on the Mind the Bleep page and also on YouTube. So you'll be able to access it later on as well. Another question is, when is the portfolio changed every year? Is it September time?
It's usually, so you apply in November-ish or start of October-ish time. It's usually changes. So a few weeks before the application, usually. But don't quote me on it. That's roughly what I'm seeing. Yeah.
Thank you. So keep an eye out, guys. They usually get posted in advance, a few months in advance. So the next question is, for audit presentation, do they need to be RCS accredited, or do RCS supported ones count?
Just do accredited, safer. There's no strict. It's not clear on the guidelines on the what's called the PDF document. So I just went for accredited, safer. Yeah.
Thank you. Another good question is, where would you advise to submit a review from an essay competition?
It depends what the essay is. I'd say if it's basic science and stuff, go for ACP, Association Clinicians of Pathology. And that's not many people know about, but they have a lot of funding, grants, and prizes that they award. So I got prizes from there. So definitely recommend going there. What else is useful? So like Sister also did one. If we did a review article in like AI in urology, if you submit it to the conference BOWS, then you can win an essay competition. Generally, the associated specialty. but you can also do it in allied specialties, like I said. Yeah, that's main things. Yeah.
Thank you.
But I'm trying to think in the question that's answering your question fully. A review from an essay competition. Yeah, that is, and the respective journals. So if it's spouse, their journal of urology, etc. Yeah, that answers the question. Yeah.
Thank you. The next question is, if for teaching experience, if I teach students on the ward and get feedback across 2 hospitals, does that count as organizing and delivering?
No, just organize 6 formalized sessions in like rooms, feedback, forms, very different speakers. Yeah, it doesn't count to my understanding. It's harder because it's a gray area. I would just be like crystal clear and do it properly, personally. Yeah.
Make sure you aim high to make sure you get the points.
Exactly.
Yeah. The next question is, when the criteria states surgically themed, does that include obs and gynae? Like, can they do an audit in the rotation, or is it best to wait for the general surgical rotation?
I just do general surgery, personally. I don't know if obs and gynae technique comes under us. I mean, that's again another gray area. I would do it either, if you have time now, go to general surgery consultants and ask them, can I do an audit? And they should, and make sure, don't say audit, I would say QIP with 2 cycles, because I think there's a lot of confusion regarding this. Make sure it's a QIP with 2 cycles. And I would just ask them, they're in the hospital, just go ask them, can I do it? And you can do it, a general surgery on recommend. I'm not sure if the answer if obs and gynae is allowed or not. It's just be on the safe side, okay, and just stick to surgery ones.
Thank you. And the last question in the group chat at the moment is if it's possible to get in touch with you regarding the ACF.
Oh yeah, yeah, sure, of course, yeah. Helps a lot of people regarding the ACF application stuff. It's very difficult. I mean, the only reason I got it again because of my seniors, so make sure you always ask. If any publications in terms of systematic reviews or anything like that, I have a few as well that I need to get done as well. So I'm happy to help with that. My email's there if anyone is interested. So generally my topics are in orthopedics and medical education. Just to offer if anyone wants to help to get a publication. But yeah, go for it.
Thank you. And a few more questions came through. So does a PubMed first author review article count as a publication?
Yeah.
Okay, yeah. You get maximum points for that.
Yeah.
Okay.
It doesn't say anywhere that it's original research. I'm pretty sure I actually did that form, I think. Let's see where it is. There we go, almost. Yeah. So first author PubMed site, it doesn't say anything about original research. So yeah. I mean, I would always, like I said, I would do original research, 1 review, and it's safe. But if you're struggling, just do a review. It should be easy, quick, and fine. Yeah.
Okay. And the next question is, do medical education conferences count as surgical related if they were accepting surgical related admissions?
Yeah, I mean, it's how you swing it. I think yes. Oh, that's a tough one. Have a look. Because I always go off this. So if it says surgical, if it's for this section, I would say just be in the safe side and don't know. But if it's for presenting, like the presentations bit, then it probably is because it's project that you're delivering nationally. But it doesn't matter which conference. So does that make sense? So if it's the surgical conferences, probably just be in the safe side. No one's actually fully sure about it. So just be in the safe side and submit to ASA, etc. But for presenting, I would say it doesn't matter.
Okay. Yeah. Thank you very much for answering all these questions. I think that was the last question in the group chat. I also put a link to the feedback form in the group chat. So everyone, if you can please fill in the feedback form, that's how you get your attendance certificate for this talk. Thank you very much, Dr. Kumar. If anyone has any questions, feel free to message us. Do you have anything else you'd want to add?
No. Just the thing is, if you have any questions, any projects or anything you want to get involved with, my email's at the end. So if you need asking questions. I think the most important thing I'd say for more of this is ask your like immediate seniors and stuff for help. That's how I got my number. So yeah, just ask.
Few last
No,
questions added at the end.
yeah,
Any experience if locum route doing MRCS versus ACS?
what's ACS? I don't know what ACS is. Yeah. Just the next question. Let him
If you can
reply.
please clarify what you mean by that. And we're going to go to the next quick question. Do both cycles of the audit need to show an improvement, or is it enough if only one does?
Show improvement. It's usually quite simple in terms of if both cycles pick the thing that shows improvement in both. So you're looking for first time you're looking at VTE, and the second time you can just say, oh, improvement was it looks more presentable. Just I would say make sure it shows improvement, but it could be different, for example. Yeah, let's answer that one.
All right. We got the clarification for the previous question. So it was MRCS versus CST.
The MRCS exam, confused. Any experience if locum route doing MRCS exam, CST training program? What do you mean? Sorry, yeah, move to the next question. Let's see it clarifies. Yeah.
Absolutely. Feel free to message us to clarify to get more information. Now, the last question is: do you get penalized by doing an F3 for CST?
No penalize, nothing. But quicker again, the quicker. It's a lot. Personally, I would do it quicker because I don't know. It's not formally penalized or anything like that. But if the quicker you get in, the quicker you get your national training number, then you can, yeah, if you need a year out, etc. I would do it. But the later you delay it, the applications are getting harder and harder. The quicker you get in, the easier it is for you. Yeah. Yeah.
Okay.
All right. Yeah.
I think that was the last question. Thank you very much.
No worries at all.
Everyone for joining.
See you guys. Yeah. Email me if there's something. No worries. Thank you, everyone.
Bye.